Hello ladies and gentlemen, this is Dan Ball and welcome to another episode of the Wellness Academy podcast. Our show here at the Wellness Academy, it is my job to distill all things wellness and attempt to break down from all our different coaches, experts and guests their wisdom and knowledge so you can apply it to your own life. Our guest today is Peter Foley. Pete is a third generation family medicine doctor based in Bristol here in the UK and is a keen proponent of a low carb diet approach. He's a keen sportsman and low carb cook and has developed a lifestyle medicine approach which he uses daily in his practice as a general practitioner. I really liked speaking with Pete and learning his wonderful approach as a GP for his clients, someone who I think empathizes really well with his patients and who really goes the extra mile in terms of caring for those people that come and put themselves in his care. I think a really interesting conversation to have with someone to give us all a little bit of an extra insight in what it's like to do that job. I hope you guys enjoy this one, and as always, the usual requests, check us out wherever you find your podcasts, like, subscribe, share, the whole 9 yards, and yeah, please enjoy, and I'll see you on the next one. So, Peter Foley, welcome to the Wellness Academy podcast. First and foremost, thank you very much for taking the time out to do this with me. I appreciate we're getting closer to Christmas. You want to be chilling out and having a good time for Christmas, but you're doing this with me, so hopefully that's still a good time as well. Thank you so much for being on the podcast with me.
Dan, thank you for having me. Thank you for inviting me, and thank you all for your listeners for clicking listen, and I hope they gain some insight and some takeaway snippets from our podcast.
That's definitely the plan. So I found out about yourself and got put in touch with you, same as a couple of gentlemen who, one I've spoken to, one I'm scheduled to speak to in the new year, via Sophie Medlin. So she was on our podcast. The episode got loaded up earlier on this week. An outstanding guest. She put me in touch with yourself. But why don't you give us a bit of an idea about what you do, how you provide value, and what's your thing, quote unquote.
Okay, Dan, I'll do my best. As your listeners can probably guess, I'm Irish, very proud Irishman. I'm living and working in the UK. I'm currently based in Bristol in the southwest. I did my medical school training in Exeter and Plymouth, and I then did my GP training in Somerset. And alongside my GP training, I did extra studies in sport and exercise medicine from the University of Bath. I'm very proud to be working as a GP in the NHS. I'm a third generation GP, so my father is still a GP working in a village in rural Ireland where I grew up. My grandfather was also a GP in the north of Ireland. So I'm very proud to be third generation GP. And I'm very lucky in that I'm currently pursuing what's known as a portfolio career. So rather than the traditional model of being a GP where you tend to work in one surgery for a chunk of your working career, 20, 30 years, I've got three main jobs, I guess. But the one which I enjoy the most by far is the traditional GP job, where I have the enormous privilege of gaining an insight into people's lives, be that looking at promoting health from a mental health point of view, helping people through bereavement, helping people through grief, looking at improving lifestyle, or managing a wide range of medical conditions. And I feel very lucky that the job I have has allowed me to meet amazing people clinically, and hopefully we'll touch on the area which I like to think I give the most value to my patients. And hopefully we'll have a discussion about that today, and hopefully your listeners will find it interesting.
I think there's two things that you just said there which I really like. One, I think it's worth highlighting that how you described what you do, how you feel like you're very lucky and very fortunate and you're very grateful. I think so. Alan Flanagan is a gentleman I interviewed yesterday, so the podcast will go out in the new year. And he was very, very complimentary of you as a GP, as we mentioned just before we started recording. And I think it can't be understated that if you go into work every day feeling lucky, feeling grateful, and feeling privileged and like proud to do what you do, I mean, wow, how fortunate are all your patients if that's the mindset that you come into work with every day versus the potential alternatives. Do you know what I mean? So that probably speaks volumes for why you're good at your job. And the other bit you mentioned that I'm interested in. So, you talk about helping people through grief.
Yeah.
One of the things that I've discovered in my life is that I think when people hear the word grief, they often think of bereavement and the grief of losing a loved one.
Yes.
But we can bereave and we can mourn the loss of a relationship. People can have grief and bereave and they can mourn the loss of a job, of an opportunity, of an experience, do you know what I mean? Like, yes, there's varying degrees of grief and bereavement and mourning, but are there any things that you help people with in terms of dealing with grief that could be applied to, let's say, for example, a really tough breakup or, the feeling of a lost opportunity that one was really relying on? Does that make sense?
Yeah, that totally makes sense, Dan. And I think in order to answer that question, I'd like to take a step back. And I think one of the challenges we have in primary care in the UK is time.
Yeah.
Time with patients and the lack of time. But when you take a step back and we use motivational interviewing techniques and you listen to people and you understand who that person is, what their experience of this grief is, and what their personal context is, you can then help them to get through that grief process. And through my medical school training, there are many grief models, but the one which I like to use is the DAB model, which is denial, anger, bereavement, depression, and then followed by acceptance. Some people will go through that grief process from denial right through to acceptance in a matter of days. Others take many, many years. And I think when you understand where the person is in their journey of that grief process, you can help them to get to the next step. And I think listening and understanding people and doing your best to contextualize them is probably the first step to help them understand that there are models of grief out there.
Okay.
And that if they say they're upset or they can't sleep or they can't eat, that can be a normal process of grief. Help them to explore that more and to understand that more. If I've concerns about safety, we have other avenues that we can go down. People are really struggling with grief and begin to have negative self-worth and feelings which are not conducive to being safe, if you like. We'll explore that more, but generally speaking, it's about understanding where the person is in that grief process. But I'm not in any way a grief counsellor, but certainly just yesterday I had a lady come in, who was in her 70s and she lost her husband 5 years ago, and she's continually grieved for him for the last 5 years. And, it's just really humbling when you're a GP and, we all live in our own bubble, don't we? And we all think we all have difficulties or concerns, and we're consumed by our own conscious and subconscious. When you see people in primary care who've grieved for 5 years or longer, that can be really humbling, and it can be really nice to see people improve along that journey when they come back and see me again. So, and I think understanding and normalizing grief for patients, normalizing processes for patients, and helping people to realize it's okay to not be okay. And no one's going to judge you for having a bit of a shit time,
Yeah, I think that's probably one of the things that I hear the most. It's okay to not be okay, which personally I probably find quite difficult to deal with. I feel like if I'm stressed, my immediate response is I shouldn't be stressed. If I'm sad,
what's wrong with me?
Be sad. Yeah. And I think. No,
go on. Yeah.
No, carry on.
Oh, yeah. I think I've had a lot of thinking about this. I guess by nature of what I do, and I think in order to be a an effective and happy GP, along with other jobs, it's important to be reflective and self-critical and understand your own journey. And I think we need to look at the world we're living in and the stimulus that we have, particularly the beast that is social media, when people put their front foot forward and their best side out, which can be damaging, because if we take social media, for instance, then subconsciously the first thing that we will do is judge ourselves on what we're looking at. I'm not as good looking as he is or she is. I wish I had their body. I wish I had their lifestyle. I wish I had their car. But you forget that there's somebody else out there who wishes they had what you have. Mm-hmm. And I think it's very easy. It's very easy to think negatively about oneself. And certainly I see a lot of that now work with people with anxiety, which unfortunately goes right down to kids now. You know, I'm seeing a lot of kids with anxiety, health anxiety, cyberbullying, and and that's really why I push kindness in my practice and in my everyday life. You know, be kind, be nice, be humble, and that hopefully comes across in my clinical practice, where you know, you have to just respect people and, you know, do your best to help them. And I think, I hope that's kind of answering your question in the way that's digestible.
Yeah. As a GP, like, what's like as a person, I'm very fortunate, so touch wood, right? I'm rarely ill, super lucky, and I do not have cause very often in my life to visit my GP. Like, whatever that is, genetic, the fact that I look after myself, I do not know, but I'm very, very fortunate. But when you do go, you visit your GP, one of the standout experiences is often that your appointment is X and you get seen at X plus 10, 20, 30 minutes or whatever. And I do always go into it and try and remind myself, probably going to be late. So there's no point getting frustrated with something I know is going to happen. And then let's have a plan of what I'm going to do with that. Like, you know, if I'm going to play a game on my phone, if I'm going to take a book, if I'm going to sit and have a breathing practice, I don't know. But as a GP, like, that must be frustrating.
Running late.
Yeah. Knowing that you're doing something, like you said, one of the things you suffer with most is time. To me, 10-minute time slots, that, like, if somebody comes in and they've got any kind of manners and they're polite and they say hello when they come in and they're polite to say goodbye when they leave, 10 minutes is 8 minutes. And you know what I mean? Like, it's just very quickly you understand why it's so difficult if you to reflect. But I don't know. I guess I'm just curious to know how.
Well, I'm
the other side.
I guess it's important to just on that. I'm lucky in that the practice that I work in and the area in Somerset I work, we adopt a 15-minute appointment policy, so that's a huge difference. And I think what I try to think about, and when I do my best to how to manage that, which can be quite a stressful environment, is once that patient sits down in front of you, your responsibility is to do the best for them. And sometimes you can do that within 6-7 minutes if it's a very simple thing. Other times it takes longer. And I think, look, when I've been to hospital outpatient appointments and you're an hour late, you think, what's going on in there? But I know myself, even as a GP, I know what's going on in there. And one of the most common greetings I have from my patients are, sorry, I'm running late. That's just the reality. And
at least you say sorry.
Well, I guess. But it's a way for me to get up out of my chair, get to the door. Almost, it's called mental housekeeping. So let's say I finish a stressful consultation with a patient. Rather than bringing that onto the next consultation, I'll get up, open the door, and welcome the next patient in, which is like a mental break for me. Otherwise, I sit at my desk for 15 patients straight, and I build up all this anxiety, all my subconscious anxiety, concern. Am I taking risks with patients? Am I taking risks? And I do that mental health hygiene. So when you sit in front of me, the difference of me being 4 minutes late and 5 minutes late is that when I sit down with you, you've got my full attention. And when I used to work in accident and emergency departments, when I was doing my junior doctor years or many different rotations, I'd have colleagues who said, I haven't had a glass of water all day. I haven't been to the bathroom all day. I'm thinking, crikey, if I was a patient and if I was offered, you can see a doctor 10 minutes late or 12 minutes late. If they're 12 minutes late, they'll have had a cup of tea maybe. They may have gone for a comfort break, or they may have checked in on their spouse. Which are you going to prefer? And obviously, you're going to prefer a doctor to give you your full attention. And that's the way I try to approach it, thinking, well, I'm going to give you best value if I'm 30 seconds late or a minute late or whatever it is late. So I think once you get caught up in that running late, ultimately, you're not going to be as effective as a doctor or as a person. And I think that's kind of the way I look at it, really, as a self-preservation. I'm 30, I'm 33. I've got a long career ahead of me, so I don't want to develop bad habits now, where I'll end up, having issues down the line.
Yeah, well, if nothing else, I like to ask that from my own personal point of view, so that the next time I'm in a GP, I've got far more perspective to be understanding about that person I'm going in to sit with, rather than getting wrapped up in my own, oh my God, I'm 10 minutes late. Do you know what I mean? Because it's...
Yeah, exactly. And also, I think as a general public service announcement, if you like, it makes our life a lot easier if you come in with an idea of what you want to get out of it.
Yeah.
And we talk about ICE in general practice, which we have in other kind of walks of life, which is, what are your ideas of what's going on? What are your specific concerns about it? And what are your expectations? What are you hoping to achieve from this?
Oh, okay.
So what can be really challenging is if you come in with problem A, but what you really want to talk about is problem B, and then we get to 7 minutes and you say, oh, actually, there's one more thing, which you actually really want to talk about. It's like, oh, I'm really sorry. Yes. So either I have a choice of either trying to challenge that or trying to address that within 3 minutes, or say you have to rebook, or, run half an hour late. So it's really interesting. So the things that you can do to help your GP is have an idea of what you think is going on, what's concerning you about it, and what you're hoping to achieve by coming to the GP. It makes our life a bit easier.
Did you ever watch House?
Yes.
I loved that show. I'm basically an amateur doctor because I've watched the episodes often. Do you know what I mean? Like just to put that out there. I remember watching an episode once where basically House was speaking to one of his employees. I forget what he calls them now, but one of the guys that works for him, and he made a screw up because he said that people always come in and they talk about what they want to talk about, but if as they're about to leave, they go to ask you something, that's really what they wanted to know. And
they talk about it. It's always, the classic one I can think of that comes to my head initially is the older gentleman, shall we say, comes in and his wife has sent him in and he doesn't really know why he's there, but actually he's really scared. He's really scared about getting prostate cancer because his friend died of prostate cancer. But he's really worried because he doesn't really know how to talk about it. He doesn't know what the prostate is. He doesn't know what or where it is, but he knows that you can die from it, and he's a bloke and he has one. So there's that kind of toing and froing about general chit-chat about health, and they'll check blood pressure and check weight and all that kind of stuff. He gets to the door on the way out. Actually, by the way, is my prostate okay? And one of our skills is to get that hidden agenda out, if it's there, for instance. It's that kind of, a lot of my consultations are done at the end of the consultation at the door, and that's just the way it is. It's those snippets of kind of healthcare advice.
So I think one of the interesting things which I've discovered that you and I, which I'm excited to talk to you about, was I mentioned this to, and if anybody listens to the podcast regularly, they probably get bored of me saying this, but essentially one of the most life-changing experiences of my life was to lose a lot of weight. You know, I used to be a person who looked in the mirror on a regular basis and was definitely not very happy with what I saw. And like, I'd be the first to put my hands up and admit I'm still left with lasting kind of quote unquote scars from those experiences. Do you know what I mean? Like,
right, yeah.
I got given a present last night. I teach martial arts for a living. I got a box of chocolates from a student. I came home. I wasn't going to eat them. I had one. One became half the box with my girlfriend.
Yeah.
I feel those 8 chocolates this morning. So I'm like, right, commitment to myself now. Like a challenge for the rest of this year is I don't need to eat lots of chocolate all the time because I don't like how I feel when I do. So let's make a commitment for the remainder of the year. I've pretty much done my chocolate, right? And these things are left over from feeling crappy on a regular basis and, you know, having concerns in my head that old fat Daniel, and just they're my words, do you know what I mean? Fat for me was whatever, it affected me mentally. But I did it doing a diet that was essentially low carbohydrate.
Right.
I remember when I did the diet, being taught this principle within the book I got it from. It was called, at the time, bike shed theory. And I don't know if it's particularly applicable over here, but the principle is, like, every bloke, I imagine, that listens, that's been to the gym and followed a training routine, has told another bloke at the gym the training routine me follows, and been told that routine is the wrong one to follow.
Yeah.
You begin to learn that you just need to go in, do your training, and keep your mouth shut. Talk to people, but you don't need to share, oh, I'm following this routine from Men's Health, or I'm following this routine from this PT or whatever, because there's always someone that's going to have something to say about it.
Yeah.
When I did a low-carb diet, and it was no potato, no rice, no pasta, no oats.
Yeah.
You know, there was also other things in it you weren't allowed. I wasn't allowed dairy. I wasn't allowed fruit. Everybody would be like, wow, that's not good. That's this, that's that. And I had to just go, okay, like, no worries, but I'm going to give it a go anyway, because it's working well for me. But that's one of your, like, not quote unquote specialties, right? Low carbohydrate diets.
Yeah. And it's interesting.
And
go
on.
It'll be helpful to give you a bit of background, but before we do, I'd like to just jump in on something you said, which was, and something that I often challenge with patients and with colleagues, is that you said, oh, I wasn't allowed. And what I try and explore with patients is even the use of language. Language can influence culture, can influence subconscious behavior.
Definitely.
Can influence guilt, right?
Mm-hmm.
I'm not allowed this. I shouldn't be having this. I'm having this. I feel bad for this. I have guilt for this. And there's a whole food guilt paradigm that we're living in. So that's something that I'm really interested that you said, because that's something that I see in here all the time, both professionally and personally. But to move things forward and to give context to your listeners, it's important to understand my journey, I guess, to where I got now. So I'm very lucky in that I grew up in an environment where I played a lot of sport when I was younger. I was lucky that I had an ability to play team sports and athletics, and I've always had a huge enjoyment out of exercise. So I never saw exercise as punishment, apart from doing fitness training. But I enjoyed sports. I have been lucky metabolically in that my weight and my physique, if you like, has been generally pretty constant. Mm-hmm. But that's probably genetic. And I used to struggle in general practice, thinking, how come so many people are just unhealthy? What is it about people who just don't, why would you smoke? I don't understand why you smoke when you know it's bad. Or why would you live unhealthy lives because you know it's bad? Because it was just so alien, thinking, well, and then that is really interesting, because then you look at your own internal bias and you look at, well, your own experience is different to everyone else's experience. And yes, you might enjoy eating a certain lifestyle and being active, but other people don't. And it's a really humbling journey to meet so many different people and different ways of life. When I was doing my sports medicine training alongside general practice, I explored the role of nutrition for exercise. And I'll be the very first to say, I'm not a dietitian, I'm not a nutritionist, and they're both very different fields, and nutritional science is vastly complicated and vastly difficult to understand. And I'm delighted you've had Alan Flanagan on to gain his insights, which is very unique, as his history as a barrister and then into into nutritional science. And with, coming at this as a simple GP within the realms of nutritional science, I thought, well, I'm seeing a lot of patients here with something called metabolic syndrome. And if we look into this, people may have heard of this, and it's different to metabolism. It's a group of lifestyle conditions which are grouped together. And I would say a significant proportion of my day-to-day life is my working life is around these conditions. Things like high blood pressure, increased abdominal circumference, or basically a large waistline, poor sugar control, poor lipid control. So bad cholesterol, diabetic or pre-diabetic in terms of type 2. And these are all very often linked with lifestyle. There's often a genetic component, but you need to have 3 of these for the constellation to have the diagnosis. And I thought, crikey, I'm seeing a lot of patients here with these symptoms. What happens then is, let's say, Dan, you come into me and you're found to have high blood pressure. We'll check out why that is, and we'll do your weight, your height, your blood pressure, do some blood tests, send you home for some blood pressure readings, and you come back. Oh, by the way, blood tests have shown that you've got something called pre-diabetes, and also you've got
what would your blood results show to say that you've got pre-diabetes? What's the thing in the blood that you've got pre-diabetes?
So it's quite interesting. You're looking at something called a HbA1c, which is really interesting, and that is a red blood cell lives for about 120 days.
Your red blood cell lives for
120 days.
Okay.
And we can gain a relatively accurate measure of how sugary your blood has been over the last 120 days.
Cool.
So that is one way in which type 2 diabetes are diagnosed. So you're over a certain threshold. And so let's say you've come into me randomly because maybe you went to a medical at work, or you used your wife's blood pressure machine, or whatever it was, or used your partner's or your friends or your own. So the interesting discussion you have with patients is, you've got high blood pressure, which often there's no symptom for. You've got bad cholesterol readings, which often there's no symptom for. You've got pre-diabetes, which there's no symptom for. And yes, you may have a bit of an expanded waistline. So you've got a hugely complicated constellation of health problems, which is not affecting you in any way because you're not suffering from it. So we're seeing so many patients who have a mixture of these symptoms presenting. And the lucky ones are the ones who present without symptoms. And sometimes people come in after they've had a stroke or a heart attack or a mini stroke, or they've got really end stage disease, because often in the early years it's essentially dormant. So I was thinking, Christ, I'm seeing a lot of these patients and looking at a lot of papers and doing my own research. I thought, there's something called insulin resistance, where basically insulin is used to put glucose into cells. If you get resistance, your body creates more insulin, and then more insulin, and then more insulin. And basically, a lot of these patients end up having type 2 diabetes. So if you break this down very kind of basically, if you have inherent problem, let's say type 2 diabetes, if your inherent problem is in metabolizing or absorbing glucose or sugar, we've got 2 options, generally speaking. Certainly what I see on the ground. We can medicate you, so we can deal with the sugar that's in your body, or we can reduce the sugar you put into your body.
Yeah.
Okay. What tends to happen, and the culture we have in the health service, which is across the globe as far as I'm concerned, as far as I can see, is, let's say what happens to you is you're diagnosed with type 2 diabetes, and you may or may not be told about lifestyle. which may or may not make any difference on your blood sugar. So you go on your first medication, which may help for a while. You'll also probably go on a statin, and then we'll check the blood sugars again. Maybe, let's say in another year's time, you go on your second medication for diabetes. In 3 or 4 years' time, you go on your third, your fourth. Finally, you end up on insulin. Your vision isn't very good. You can't feel in your feet very well. And that's what we tend to see. So the approach that I have is, for some people, that's the way that their diabetes is managed. But for others, I say, let's bring this right back a second. Dan, let's say you're my patient. Do you understand what diabetes is? Do you know what it is? And do you know what these tablets are taking are for? And once we just explore that, and a patient's experience of diabetes tends to be, they get blood taken every year. They're told whether it's good or bad. If it's good, they carry on. If it's bad, they take more medications. Their diabetes isn't affecting them in any way, apart from taking medications, and that's generally how it tends to go. I like to turn it on its head, and I say, well, your issue, I say, listen, I'm really sorry that you've got diabetes. It's often not your fault. That's the first thing to say. There's no blame here. Do you want to try an approach which will change the way you eat food, which is not a diet? I don't see it as a diet, but it can dramatically improve your control of blood sugar, and it may result in weight loss. It may result in mental clarity, and it may result in us removing some of your medication. And most often people say, yeah, let's give this a try. And then we discuss food in its most basic form, macronutrients, and essentially we talk about starch. And what starch is a chain of glucose molecules.
Okay.
That's all starch is. So once we say to patients, and what I often do if they want to try this, I say, you've got your blood sugar reader at home, carry on eating the way you currently are, and come back to me in a week or come back to me in 2 weeks and show me what your blood sugars are doing. And it's important to also say they take blood sugars before their meal and 2 hours after them to get an idea of what the trend is going to be. And often what will happen is their pre-sugars might be about 8 to 10, and their post could be as high as 18, 19, even 20. I then say, right, so you've done that bit. Let's look at other foods. Can you reduce your breads, your pastas, your rices? Can you increase your green leafy vegetables? Have your dairy, but rather than having fat-free, have unsweetened, unflavored, normal fat levels, if you like. Eggs, meat, fish, and try that. And then take your blood sugars before and 2 hours after and come back. And often they say, my goodness, I've no idea. I'm eating plenty of food. I'm feeling nicely satiated. And often they eat less. And just because their appetite changes. And their blood sugars stay stable. And then once they've seen the results for themselves and they've gone through that beginning of the journey, we look at hope. We look at what they want to achieve. And we look at beginning a journey with them. And most recently, the most recent success I had in clinic just this week was of a lady who suffers with type 2 diabetes. And we had this discussion back in May. I've seen her 3 times since May. And both her and her husband, who I've never seen, have lost 38 kilograms between them. And her type 2 diabetes is now in remission.
That's
she's
good
not
work.
taking medication. She's not taking medication for it anymore. And I discuss things like what you said about allowed. I don't really talk about good or bad or allowed. I don't talk about portion sizing. I don't talk about counting calories. I talk about focusing on foods which are going to make the least impact on blood sugar. And that can often result in significant weight loss for people. Often it doesn't have to. But my primary focus is on reducing their blood sugars because that is the problem long term. And if we take things right back from a type 2 diabetes perspective, essentially what happens is if you have type 2 diabetes, which is poorly controlled, you become sweeter. Your sweat is sweeter, your blood is sweeter, your urine is sweeter.
Okay.
If your urine is sweeter, bacteria can grow on that urine. You can get infection in your genitals. If your sweat is sweeter, you can get infection in your skin. You can get thrush in your groin, thrush in your, thrush under your armpits. If you have type 2 diabetes, which is progressive, which is very severe, your nerve endings get very sweet, and that can be toxic to your nerve endings. What happens then is you don't necessarily know if your shoes are too tight. You don't know if you've walked on a nail. Yeah. And the issue then is you've got a wound on your foot. That then gets infected because your blood is sweet and your sweat is sweet and your skin is sweet. You then haven't got the response you normally would have in terms of your immune system, immunity. You might then have to lose a toe or lose a foot. You might then have an amputation of the knee, and then you've lost a leg. So that's the reality, and that's what I see. And I had a job as a vascular doctor when I was working in Belfast, and we did amputations all the time for people with type 2 diabetes.
Wow.
So that's the reason.
So you could say all the time. That's
oh yeah. I mean certainly weekly.
Jesus.
So that's what we're talking about, and that's the reason I'm so passionate about this. Like, let's take type 2 diabetes and cost. So we spend something in the region of £1 billion a year on medication for diabetes alone in the UK. There's data which we can freely access, which shows certain counties in the UK are spending up to £1 million a month on diabetes medication. That's a huge problem. So that didn't really sit well with me as a young doctor, thinking, well, either I can be part of this problem or I can do what I can to give several people kind of one-to-one advice, hope, and guidance to reducing their blood sugars to get them off medications. And that's what I'm about. And through that, I've done other work, which is why I started a social media presence, to show, a low carbohydrate diet can mean many things to many people. Looking at official definition, is less than 130 grams of carbohydrates per day. That's a lot of spinach. It's a lot of cruciferous vegetable, but it's not very much, in the way of bread, pasta, rices, or refined cookies and cakes, right? No. So that's what drives me, is doing my bit to give people a bit of hope, to give them a bit of guidance, and to give them a chance to dramatically improve their life by making simple daily changes. And it can be very overwhelming for people who said, I've heard you're the guy that you lose loads of weight for patients. But I bring it back to, what's your story? What's your journey? How can I help you? Like, I'm here to do my best, but I have to understand who you are. And I use different techniques. There's a great quote: you have to bait the fish. You have to bait the hook to suit the fish.
Yeah.
So if I have 10 different patients with type 2 diabetes, I'll approach each 10 different. I don't necessarily offer to every patient. Depends where they are on their journey. Depends what else they have going on in their lives. Depends what family support they have. Who does the shopping at home? Who does the cooking?
Yeah.
And I break things down. I say, if you have 3 meals a day, that's about 84 meals a month. Can you have 50 of those where you reduce your carbohydrate intake? Can you just say, can you change your breakfast from cereal every morning to, let's have eggs? Or there are ways to look around it to break it down simply. And there's another great quote, how do you eat an elephant? One small bite at a time, right? Or the other one is, I use it all the time in clinics. How do you boil a frog?
Gradually.
Have you heard that one before?
Yeah, gradually.
Yeah. Put it in cold water, and before it knows it, you've boiled the frog. So, I look at these concepts, and there's no magic in what I do. But I think for some people, hearing it coming from a GP, where I say, I'm not going to give you more medication. I'm going to give you a chance here. What's important to you? How can we give you the information you need to make an informed decision to make improvements? And that's the thing that people really love, is that, I guess, and this is in no way a slight to my wonderful colleagues, all who are doing an amazing job, but we often forget to take a second and actually listen to the patients. And I've challenged myself early on in my career, rather than being that doctor who looks at the screen all the time, look at the person, listen, what's the story? And I find working together with people, identifying who they are, what they want to achieve, that is, half the battle.
So, if I try and take two different kind of tracks with this. So one, when you say about blood pressure, I know that I was not too long ago, I was in the GPs with my girlfriend. She was visiting. I was with her. They had a way to get a pressure monitor in there. Like you just put your arm in. My blood pressure was bang on what it needs to be, right? So not concerned too much about blood pressure. Generally speaking, I think that I do a good job with diet, and I'm not worried about my waist circumference. But I also know, like from a genetic standpoint, and you talk about comparing yourself to people online, like social media. I tend to store quite a lot of my body fat around my hips, and it's like, it drives me insane, and I don't like it. And I find myself looking at other people like, that guy's my age, why hasn't he got that there? Blah blah blah. So, and if I look at my dad, if it is genetic, him and I have quite similar body types in the sense of where we store our body fat. So if I was to think to myself, okay, stereotypically it becomes harder to look after oneself as you get older. Like, the old statistics about what muscle mass you lose every year or every 10 years past whatever age it is. So from my point of view, as somebody who feels like they're relatively healthy, if I was going to tick 3 boxes in terms of, right, here's some easy, low-hanging fruit to take care of as I go into, we're the same age. So as we approach 40, as we approach 50, what can I do? And on the flip side, my mum has been that person that goes to the doctor. She has high blood pressure. She also knows that she has aneurysms in her brain. She had a burst one this year.
Scary stuff.
She's very fortunate to be here. She had her 60th birthday party last weekend.
Wow.
She's very, very fortunate to be at that 60th birthday party. And I'm that person sat at home frustrated that she goes to the doctor, and to help her with her blood pressure, it's just a new tablet. And I'm like, just.
And I think, I guess it's important not to give out medical advice. And I think it's, for me to do that. But I think,
I don't necessarily mean medical advice, though. So, like, from my mum's point of view, when you say about what foods, so I'm thinking to myself,
totally.
What foods would she go, okay, as long as this is on my plate, even if I'm just making one small incremental improvement, like, what would I add? Like, what are the, you know what I mean?
For blood pressure?
Well, let's say, for example.
Well, here's the thing. We don't know what causes high blood pressure for 95% of people.
Okay.
We've got something called primary hypertension. You've got secondary hypertension, which is caused by other diseases, kidney disease and other more complicated diseases of imbalances of electrolytes and things. But for 95%, we don't actually know what causes it. We know it's really serious. We know it's very important to get right. But I would imagine, certainly, if your mum comes to me, she's had a significant risk of having an aneurysm in the brain, or possibly several.
Does high blood pressure equal a higher risk of those aneurysms having a negative, of them bursting? Is that a fair correlation to make?
That would be, yeah. Now, I'm not a neurosurgeon and I'm not a neurologist, but certainly you're looking at volume, you're looking at shear forces, you're looking at pressure. Mm-hmm. And what you've basically got is a hose where you've got an out bulging of that hose. So it would make sense to reduce the pressure on the system.
That's what my brain said anyway.
Yeah. So looking at your mum or anybody who you want to reduce blood pressure, it all comes in alongside lifestyle measures. Yeah. We know that there's significant evidence to suggest your cardio or respiratory fitness dictates. It's one of the leading.
So
things
Peter,
that you can do.
she's got no cardiorespiratory fitness. Like that's point one.
Yeah. So I mean, what you want to do is look at the whole person. Yes, you can, and this is what's interesting to challenge. You know, you can treat the blood pressure, you can treat the person, or you can treat both. So you know, someone like your mum, you're looking at what I like to term, you know, a lifestyle optimization program.
Mm-hmm.
Can you reduce your sedentary activity? Can you look at your overall health? Can you improve your sleep? Can you manage your stress better? Can you improve your cardiorespiratory fitness simply walking? Or, you know, there's lots of daily things you can do on a consistent basis, which is going to make it the best return of your outcome. And I mean, looking at your mom with high blood pressure, you're going to want to get that down with medications because they're alongside lifestyle interventions, because that's a significant risk, you know.
Well, I think of like simple things like, and I mention these just because I think they're really good low-hanging fruit for anybody that listens, like parking your car in the furthest car parking space away from where you're going, making sure that you take the stairs rather than the elevator or the escalator. You know, when you walk up the stairs,
and you know what, Dan? It's doing that over 40 years.
Yeah, exactly.
It's doing that consistently over 40 years. It's like you go to the gym because you want to work on your shoulders. Let's say, for instance, you know, do you just stop after the first session?
Oh no.
If you're a child, if you've got a child and you're teaching them to tie their shoelaces, they can't do it first time, do you tell them to stop trying? It's consistently doing it over and over and over and over again. Exactly, over and over again. And it's looking at that, and that's why I look at, you know, when I look at my patients with metabolic issues, type 2 diabetes, for instance, looking at diet, you know, life isn't pass or fail. It's not black or white. If you have one bad meal, you know, that's not going to make a huge difference in the course of your life.
Yeah,
it's what you do consistently over time to change behaviors, which is what I'm kind of all about, really. So then all of a sudden, you know, 6 months down the line, for some people, or depends, there's interpersonal variance, you then begin to make automatic decisions subconsciously. Yeah. And that's what I kind of get into with.
So, what about, because obviously I appreciate one of the most difficult things is the eagerness to change. You know, I remember listening to old Tony Robbins' Personal Power 2, like and neuroassociative conditioning and neurolinguistic programming both start with the willingness to change. Like I remember he talked about, I mean, that program was out 30 years ago or something ridiculous. And like back then he would say that his personal clients, he charged them $1 million, made them fly out to Fiji to his resort. And then when they got there, he'd say, I don't think you're right for this, to make them want to change.
Well, that's interesting. And what I find to run with that, Dan, I went on a huge journey of kind of self-discovery, which sounds dramatic, but the reality is I spent my first couple of years as a GP or a doctor saying, I don't understand why you're not listening to me. I know what you need to know, but it just won't go through.
Mm-hmm.
Which was it's a normal thing to do, but in hindsight, can be a bit obnoxious, I guess. But it was coming from a place of wanting to help people.
Yeah.
But now it's thinking, well, hold on a second. Who are you? What's your story? What's important to you? Mm-hmm. And it's rather than saying, how can I make you do what I want you to do? It's, well, hold on a second. What's important for you and how can we get there together? And that's what I now do is, you know, I'll tell you that, and I'll give you an example. I saw a patient in his 70s and he was sent to me, you know, which I see a lot, you know, he's sent in to lose weight. And I said, listen, we'll call him Bill. Listen, Bill, what do you want to achieve out of this? Because I knew what I wanted to achieve for him, but I wasn't going to impose my views or goals on him. And he said, you know what, Dr. Foley, if I can tie my shoelaces and knock it out of breath, I'll be happy. And I was thinking, wow. Right. I said, right, let's start with that. And we managed to lose 20 kilos over 18 months. And he now said, you know, I can now cut the grass in one go. And that one example tells me that, I would have loved him to say, I want to help my blood pressure or my cholesterol or my diabetes. He doesn't care about that. He wants to tie his shoelaces and not get breathless. So when you flip it on its head, and rather than saying, I'm Mr. Information and I'm going to give you what you need to know, it's actually, okay, I've got the tools, I've got many tools, but actually, where are you at, and how can I then digest that and pick out the tools you need from my toolbox?
Yeah.
So that's kind of how I do it.
I like that. So, what are the kind of things that you're making sure that the boxes that you tick I remember when you think about 33 as an age, like I do find myself now thinking, okay, hopefully
33.
Yeah, hopefully I've seen a third of my life, ballpark, touch, give or take. I mean, that would be nice, okay?
Yeah.
If I'm lucky. So let's say that's the case. The next third of my life is very, very important when I factor it into the final third of my life. Like what I do for the next third of my life is dramatically important. I can't wait for another 10 years to want to make changes, and I'm
with you.
Conscious of that, right? So do you have any boxes that you tick physically, mentally, but also in the context of what you know as a GP and your learning?
Yes, absolutely, Dan. And that's a very good question. And I hope this is kind of a final leaving snippet, I guess, a soundbite. But on a daily basis, I'm reminded of the fragility of life. And during my junior doctor years, it's frightening how life can change within a split second. And when you spend your time going around nursing homes seeing dementia, you see people who are very frail or people who have succumbed to lifestyle-related conditions. It makes you really look internally. And I feel an enormous responsibility to myself being exposed to all this. What am I going to do with that information myself?
Yeah.
And I like to look at my own kind of personal tick box, like the spokes of a wheel.
Yeah.
And I've got sleep, fitness, strength, nutrition, family. And I'll give myself a mark out of 10 on how that is. And having 10 out of 10 on everything, it's a perfect circle. But the reality is life isn't like that. So I'm a big fan of rugby and like listening to my podcasts. And I'm sure many of your listeners will know who Brian Driscoll is. And he recently was on a podcast talking about sport performance. And he said, if you try and improve yourself 1% every day or every year consistently, you'll be your best chance of being a better version of yourself. And I realize now I'm quite selfish in the way that I need to be optimizing my own health, my own mental health, my own performance to be the best husband I can be, to be the best friend, to be the best doctor I can be. So I get my 8-9 hours sleep a day.
Okay.
I eat consistently, let's call it a low carbohydrate diet. It works for me digestively. It works for me energy-wise. I eat between 2 or 3 meals a day. I rarely snack. Drink alcohol occasionally. Don't smoke. Try to get regular exercise in the form of resistance training or gym training. On average, 2 times a week, I'd say.
Okay.
And if not that, get some walks in at lunchtime. I'm the guy who parks the furthest away in the supermarket. I'm the guy who takes the stairs in the tube. And when I'm told I've got a diagnosis, let's say I'm well into my 80s at this stage, when I'm given that news, I want to look back and say, you know what, I did everything I could to either avoid this or prolong this. And it's really difficult when you see people who've come into me in their early 40s with a diagnosis of type 2 diabetes, had a heart attack, and they've got already the horse is bolted and they've got end-stage organ disease. So that's my thing. And ultimately, having a positive mindset, being humble, and being kind. That's my 3 takeaways. Because I think the world needs a lot of kindness. The world needs a lot of hope, and I do my bit to kind of spread that as best I can amongst my my patients.
Yeah, that's
Does that
cool.
answer your question?
Yeah. I like it. And like when you said about strength training a couple of times a week, a very specific question. Does that mean that you try and do full body?
Yeah. So you know, I don't make it overly difficult, kind of deadlifting, squatting, body weight stuff. Not training for anything in particular at the moment, but really, as a GP, I'm well aware of the issues of back pain. So I try and prioritize my posterior chain work, looking at my lumbar area, my buttocks, my hamstrings, key to get all that all right from an early age. And I guess one other thing is to really limit screen time. I try and have at least an hour.
We both say doing an interview on a laptop and a phone.
Yeah. But I mean, to give you context, I would have at least an hour in the morning and in the evening screen time, screen-free time.
Yeah.
Sunday, I try and keep screen as off social media and things if I can. And really, I think what I've really benefited from in the last 18 months is prioritizing sleep. Seeing sleep as a really important tool for mental health, for physical health, and when you look into sleep, it's fascinating. And as kids, when you see children and the bedtime routine, it becomes a bit of a religion in certain families. The kids have to get to bed on time and routine, and I think we lose that as adults. But actually, since I've looked into this further, and I set myself a challenge of improving my sleep, I feel much better for that. So, looking after yourself and doing what you can with the information you have to make the best consistent lifestyle changes to be your best version of yourself.
Yeah, I'm right there with you. Cool. Yeah. Okay. So, last thing I normally ask people is where can people stay in touch with Peter Foley? Where's the best place to keep up with you? Like, what's what have you got going on? What does 2020 look like? Blah blah blah.
So, for those of your listeners who haven't heard of me or who want to kind of see more, I'm on Twitter, Dr. Peter Foley. I'm also on Instagram at the same. I've recently joined TikTok, which is quite fun.
I haven't done that yet.
I'm trying to learn it. So if they want to get in touch or ask a bit more, or hopefully they'll give a good review for you. I really like what you're trying to achieve. I really have enjoyed listening to the rest of the podcasts, and I feel very honoured to be asked to be put forward and to be part of a great team of guests for you.
One of the things I'd love to do, like at some point, because I think fingers crossed as I approach kind of January, February. So we started this podcast in around May of this year. Then there was quite a break in between the first 5 guests, and then kind of going from there. But if everything kind of goes to plan, by the time January, February comes around, I'll be on like the 40 episodes mark. And it's like you end up finding that a lot of people are in similar areas of England, and obviously London is a hub for a lot of people. I do have cause to be in London for a CrossFit sanctioned competition for the CrossFit Games at Strength in Depth in London, the penultimate weekend of January. And I'm gonna what I will do is message out to kind of the people I've spoken to, and if there was a way to do like a podcast meetup, I just think that would be a super to try and do. Absolutely. So I know that Sophie has opened her new kind of clinic down in London. I think it's called Nemaya, I think.
Okay.
And I mentioned to you about before we were recording the gentleman that I know that she knows, Richard. He was there the other week, and I would love to try out the float tank. I would love to try out the cryotherapy chamber. And if there was a way to kind of join all that up, I'll try my best. And that would be really cool to get the chance to meet lots of people in person. So,
Yeah, I hope this has been of value. I've certainly enjoyed it. It's been quite meandering and quite loose, but hopefully people have found it useful. And just trying to spread kindness and humility and working hard and doing our best.
I think that's probably a brilliant place to end, Pete. So thanks so much for your time. And I'm also glad that your iPhone battery has lasted for the hour.
I'm very impressed. I'm very impressed.
Go iPhone.
I'm getting, go on.
Right, cheers, Pete. Thank you.
Cheers, Dan. All the best.
This is Dan Ball from Wellness Academy. I really hope you enjoyed this podcast. Please subscribe on Apple Podcasts, Spotify, or wherever you're listening right now. You'll find a link on the episode notes. Just tap or swipe over the cover art. You'll also see some offers from our sponsor, Lichfield Apart Hotel. Find them at lichfieldaparthotel.com, and we hope you'll support our show by supporting them. If you like what you've heard, we'd love it if you could give us a 5-star rating and tell your friends how to subscribe. Another way to support us is to answer a short survey at yourwellnessacademy.co.uk/survey and tell us what wellness topics you'd like to hear about. I'm your host, Dan Ball. Our producer is Scott Towns, created by our executive producer, Ben Heathcote for Wellness Academy.